a review of the terminology so that we can approach at the beginning on the same level. We'll look at benign calcifications, malignant calcifications, and as you've already seen, algorithms are getting popular. I'll show you an algorithm. Calcium is a silver-white bivalent metallic element of the alkaline earth group. And calcification is the deposition of calcium salts in the tissues. Usually it's in the form of calcium phosphates. For the terminology I'm going to use, I'm going to refer you to the BIRADS, or the Breast Imaging Reporting and Database System approach that was developed by the American College of Radiology through a committee that was assigned to that task in order to bring standardized terminology and reporting to mammography. With that system, calcifications are defined by their morphology, their size, distribution, and location. And all of these terms are not only descriptive, but should be related to the likelihood that a lesion is malignant. For the morphology, calcifications are generally classified as typically benign, intermediate, or those that have a higher probability of malignancy. Those that are typically benign include skin calcifications. These typically have lucent centers, and if we're uncertain that they're in the skin, we can verify their location with tangential views. This is an example of a case that was sent in for a mammographic localization procedure. On one of the views, the calcifications are relatively close to the skin, which always raises our suspicion that they might be in the skin. With a whole plate placed over the breast at the site closest to the calcifications, the breast and the C-arm are rotated until, with a compression device placed over the skin that has an open window with an alphanumeric grid or a whole plate, either method, a compression plate with multiple holes. An image is taken to verify the location of the calcifications. With the compression device still on, the image is reviewed, the location of the calcification is determined, and a BB is placed exactly at the site that the calcifications are at. So it lies right over the calcifications on this view. The breast is then rotated slightly and the C-arm primarily rotated until this BB is tangential to the X-ray beam. And with the colorimeter light on, we usually are able to see a cast of the BB on the bucky below. And we can see it right here, and that proves that it's a tangential view. With that maneuver, we can determine whether or not the calcifications are in the skin. If they're in the skin, the woman goes on to just routine follow-up, probably a screening mammogram 1 year later, because skin calcifications are always benign. Coarse calcifications describe generally fibroadenomas. They can either be popcorn-like, like this. They may be on the rim of the fibroadenoma, but these two are always benign. In this case, there are also vascular calcifications, parallel tracks, again, typically benign calcifications. There are also large rod-like calcifications that are typically benign. These, unlike carcinoma calcifications, are solid, not made up of multiple microcalcifications, but solid calcifications, and are typically associated with a condition called ductectasia, sometimes called secretory disease. And these calcifications are usually more separated than those of malignancy. They don't branch generally, as malignant calcifications tend to do, and are easily separated from malignant calcifications by these morphologic features. There are round calcifications that occur in the acini, and these calcifications have typical features, but we can't always tell that they're benign. But when they're typical in terms of the geographic distribution, they're not biopsied. In this case, because they were clustered in groups and in only one part of the breast, they were biopsied. But the case provides a nice example of their round shapes. Rim or eggshell calcifications are often associated with fat necrosis. You've already learned about fat necrosis. It's a post-traumatic condition where the fat undergoes necrosis and the fibrous capsule around this dead area of fat may calcify, giving us this kind of a thin eggshell appearance. These too are always benign and do not require any intervention. Milk of calcium, another typically benign type of calcification. Again, these calcifications are in the acini, in tiny cysts within the breast, which come from the acini, dilated because of excess fluid production, and the calcifications in them tend to float, so that on the craniocaudal projection, they look round and amorphous, and on the medial lateral or 90-degree lateral projection, they layer. This kind of sediment is classic for milk of calcium, and these do not need to be biopsied. But since milk of calcium arises in the same location in the breast as most breast carcinomas do, and that's at the terminal duct lobular unit, it is important to scout the area carefully to make sure there are no other calcifications that might be malignant. If they all look like this, however, a biopsy is not necessary. In addition to the typically benign calcifications, there are the intermediate concern calcifications, and these tend to be indistinct or amorphous, sometimes called flake-like, small and hazy, and it's very difficult to determine whether these are benign or malignant. Here's an example of one of these groups, probably very hard to see because they are hard to see on a mammogram, particularly if they're located in an area of density, as these are. In fact, these were biopsied and did represent malignancy. So these can be malignant or benign. And then we have a group that has a higher suspicion for malignancy or a higher probability of malignancy. These are generally of two different types, pleomorphic or heterogeneous, which are tiny granular calcifications, usually less than 0.5 millimeters, that vary in size and shape, that are localized in clusters, and are sometimes associated with a mass that could be malignancy, so this could be invasive and intraductal carcinoma. These type need to be biopsied. While they're not always carcinoma, there is a higher likelihood that they might be, and this was, in this case, multifocal carcinoma. The fine, linear, and branching calcifications that are shown here have an even higher likelihood of malignancy. Unlike the secretory calcifications that we looked at earlier, these are more clustered. They often have branching associated with them, and they're made up of multiple groups of calcifications rather than one solid calcification. But they are located in the same place they're within the duct. In this case, they're usually in smaller ducts than secretory calcifications. They're thin, irregular, and discontinuous. And while small, they're not usually as small as the granular calcifications. Now, in addition to the morphology of calcifications, we also look at their distribution. Calcifications can be described by distribution as grouped and clustered. Now, while this may be associated with malignancy, it also occurs in benign conditions, so this is a neutral modifier until we take into consideration other features. Grouped or clustered simply means there's multiple calcifications in a small volume of tissue. Linear indicates that the calcifications are arranged in a line. And here we can see these tiny clustered calcifications are lining up as if they're within a duct, and it has a branch point here and a branch point here. This is suspicious for malignancy. Segmental suggests deposits in a duct, like we just saw, but also more of its branches. So it looks like it's in a larger segment of the duct system. These two, when they have granular or linear and casting features, are suspicious for malignancy. Regional calcifications are scattered in a larger volume of breast tissue, which doesn't necessarily conform to a duct distribution. Here's an example where these calcifications were diffusely found in both breasts, but they could be regional as well, and they're likely to be benign. And when we say they're diffuse, what we mean is randomly found in both breasts, and that's an indicator of a benign condition. One specific type that we should mention is the carcinoma that is extending over a wide area and may be associated with a mass or may not be. And that's when it is over a wide area and it's carcinoma, calcifications representing intraductal carcinoma, we call it an extensive intraductal component. So that if this carcinoma, which is invasive, has an associated intraductal component that extends over a significant area, it's called EIC positive. And the reason we want to draw attention to it is that following lumpectomy and radiotherapy or breast-conserving surgery, these cases have a higher incidence of recurrence, probably because not all the tumor is removed. So that they have to be particularly watched by the radiologist. The radiologist plays a very important role in the management of these cases. For example, it may be important to, when doing the localization procedure prior to lumpectomy of a case where we've already got a needle biopsy diagnosis of carcinoma, to make sure all the calcifications come out, we may want to bracket the case, put a localization wire on both ends of the non-palpable area to make sure all the calcifications are removed. In addition, after surgery for lumpectomy and prior to radiotherapy, we routinely do magnification views over the area of the scar. We usually place a wire right on the lumpectomy scar and do magnification views before radiotherapy begins. If there are residual calcifications present on that film, then it's important that they be removed, and if they're too extensive, that consideration be given to some other alternative therapy, such as mastectomy. Most of the time, they can all be removed. Here's an example of a case where the specimen radiograph shows a large number of calcifications, and this was a specimen of a lumpectomy. This woman was worked up the way we usually work up women today in our center, and that is that her biopsy was done with a core biopsy, and with the diagnosis of carcinoma made on that core biopsy, then at the next step, with the open, instead of an open biopsy, she went on to a definitive breast-conserving surgery, and these calcifications were radiographed in the specimen because the localization occurs prior to the lumpectomy. This is a non-palpable lesion. When the woman came back 4 weeks later to have her pre-therapy mammogram films, her pre-therapy mammograms with magnification, we put a wire over the area of the scar from the previous surgery, and when we did the magnification views, we saw residual calcifications. So that woman had to be relocalized. If these were not removed prior to radiotherapy, they'd be noticed on a 6-month image and thought to be recurrent carcinoma. In fact, they're residual tumor, and they need to be removed in order to have successful treatment. Now, once we've looked at all the features of the calcifications, we have to make a judgment as to the likelihood of malignancy, and to do that, we again use the recommendations of the BI-RAD system, and we put it in one of these categories. Having used the mammograms to determine the likelihood of malignancy based on one of these categories, which would be either benign calcifications, those that we're uncertain about but have a very low a very high probability of being benign and low probability of malignancy, we would do a 6-month follow-up. So these categories help us determine what we're going to do with these calcifications in terms of our management. And then we do an algorithm. Now, the reason I'm doing the algorithm is because management is beginning to be more and more turned in this direction, so we have to start thinking about it. And these algorithmic approaches in the branching of what we do should be based on evidence in the literature and expert opinion, not just randomly and different from every one practice to another or one radiologist to another. Eventually, it's thought that there'll be algorithmic approaches for almost every condition. And in fact, there are groups working on these, including the Agency for Healthcare Policy and Research, which is working on clinical algorithms. American College of Radiology is working on diagnostic algorithms, which are called appropriateness guidelines. And this is sort of the approach that we'll probably see more in the future, so that what we do is justified and also rational and rather standard from one site to another. Calcifications identified on screening or diagnostic examinations, for example, could be classified as definitely benign, in which case we would stop a workup. We wouldn't do any workup, but we would do routine follow-up on that woman in terms of screening. By definitely benign, we'd be thinking of the kinds of calcifications we saw earlier. Skin calcifications, we proved were in the skin. Milk of calcium, none of those would need to have any intervention. Sometimes we're uncertain about what the nature of the calcifications is, and then in that case we may have to do a little more workup, such as magnification. In the case of milk of calcium, sometimes you can't be sure that it's really milk of calcium without doing a 90-degree lateral view in addition to the standard views, which are MLO and CC. On the other hand, sometimes the calcifications are so obviously malignant and well-defined on the original mammogram that there's no reason to do more workup. They can go right on to biopsy, which might be a core biopsy or an open biopsy. If they are not that certain, then we can classify them as a result of the magnification views and our diagnostic acumen is definitely benign again, so that they don't need further workup. They may turn out to be probably benign, which means that the chance of being malignant is very low, and we wouldn't want to biopsy those cases because the yield would be too low, so they would go into a 6-month follow-up category. And those that are suspicious would go on to workup. We can see that laid out here. For those that are suspicious or highly suggestive, needle localization and biopsy, or core biopsy, or fine needle aspiration. When we do core biopsy on calcifications or fine needle aspiration, there is a possibility that calcifications that we were almost certain were malignant will show benign fine needle aspiration or core biopsy. If we have no way of verifying that that's a correct diagnosis, we may have to go on to an open biopsy. So that is the risk you take with the core biopsy of the fine needle, that you won't get the diagnosis. It doesn't happen very often in our practice, but we did have one case last year where the calcifications looked very suspicious, and we only did the core biopsy in order to expedite the workup, to avoid an open biopsy so that the woman could get a diagnosis and go right to one surgical intervention, which would be therapeutic. In that particular case, the core biopsy turned out benign. When that happens, we have to take everything into account, and if the discordance can't be explained in some way, we need to go on to a needle localization and open biopsy. In that case, core biopsy wasn't cost effective, it added expense. In most cases, that doesn't happen. Another situation where the core biopsy or the needle biopsy may not give you correct answers is when the core biopsy shows atypical duct hyperplasia. In that case, we do an open biopsy because that may be associated with adjacent carcinoma, and we simply sampled the wrong area, or sampled the area where it was benign rather than malignant. And with fine needle aspiration, a certain number of cases, will have insufficient specimens. And in those cases, they need to go to open biopsy as well. Once the diagnosis is made, if it's malignant, then of course we usually go to breast conserving surgery, because if the woman was in a screening process, then it should be an early abnormality. And pre-therapy mammograms are done prior to the institution of radiotherapy. Occasionally, the woman will have a mastectomy, and there are multiple reasons why that might happen, including her personal choice.